Dr. Carhart warned veterans, unilateral pain may hide benign tumor in auditory nerve. Have you ever felt an ear pain that seems different from others? A pain that doesn't improve with common painkillers and affects only one side? What if I told you that this apparently simple pain could be the first sign of something that thousands of war veterans face silently, but which conventional medicine often ignores until it's too late? I'm talking about a condition that renowned Dr. Raymond Carhart first identified in 1945 when he was working with World War II veterans. He discovered that many soldiers who had been exposed to explosions and intense combat noises developed not only hearing loss, but also benign tumors on the auditory nerve that caused specific and progressive pain. If you watch this video until the end, you'll discover exactly how to identify the first signs of this condition, why it's so underestimated by conventional doctors, and most importantly, what to do when you suspect that this unilateral pain might not be just a common earache. What Dr. Raymond Carhart discovered in his studies with World War II veterans revolutionized our understanding of the late effects of acoustic trauma exposure. He observed that soldiers who had been exposed to grenade explosions, artillery fire, and other intense combat noises developed, years later, a specific condition that he initially called post-traumatic acoustic neuroma. Acoustic neuroma, technically called vestibular schwannoma, is a benign tumor that grows on the nerve responsible for hearing and balance. Unlike other tumors, this one is not cancerous, but can cause serious problems due to its strategic location in the cerebellopontine angle, a delicate brain region where multiple cranial nerves meet. Dr. Carhart was a pioneer in establishing the connection between intense acoustic trauma exposure and the later development of these tumors. His initial studies, conducted between 1945 and 1952, followed more than 1,200 veterans for periods ranging from 5 to 15 years after the war's end. Why is this discovery so relevant today? Because we're dealing not only with veterans from past wars, but with a new generation of veterans from Afghanistan, Iraq, and other recent conflicts, as well as industrial workers exposed to intense noise, professional musicians, and even people who regularly frequent environments with very loud music. Dr. Carhart's work showed that there is a typical latency period between initial acoustic trauma exposure and acoustic neuroma development. This period generally ranges from 10 to 25 years, which explains why many veterans only start showing symptoms decades after leaving military service. In 1963, Dr. Carhart published his most comprehensive study in the Journal of the American Medical Association, documenting 237 cases of acoustic neuromas in veterans. He observed that 82% of cases presented unilateral pain as the first symptom, frequently described by patients as a deep, constant pain that gradually worsened over months or years. What makes this pain so characteristic? First, it's almost always unilateral, affecting only one ear. Second, it has a specific quality that patients describe as deep pressure, different from common ear pain caused by infections. Third, it generally doesn't respond well to conventional painkillers and tends to worsen with atmospheric pressure changes or sudden head movements. But here's what worries me most. How many people do you know who have chronic ear pain and simply live with it? How many doctors adequately investigate persistent unilateral pain in patients with a history of intense noise exposure? The answer is very few. Let me tell you about a specific case that Dr. Carhart documented in 1968. James Patterson, a 38-year-old World War II veteran, sought medical attention 14 years after leaving military service. He reported right ear pain that had started as mild discomfort 3 years earlier, but had progressively intensified. Patterson had served as a gunner in a Sherman tank during the Normandy campaign, being exposed daily to explosions and cannon fire for more than 8 consecutive months. Initially, doctors treated his pain as a chronic ear infection, prescribing antibiotics and anti-inflammatories for more than 2 years without success. It was only when Patterson began experiencing progressive unilateral hearing loss and episodes of dizziness that an otolaryngologist suspected something more serious. Tests revealed a 2.5 centimeter acoustic neuroma on the right auditory nerve, a discovery that completely changed the course of his treatment. Patterson's case perfectly illustrates why Dr. Carhart's discovery is so important. He not only identified the connection between acoustic trauma and acoustic neuroma, but also established the diagnostic criteria that are still used by specialists worldwide today. Now, you might be wondering, how do you know if an ear pain is just common pain or something more serious? Dr. Carhart developed a list of warning signs that are still considered the gold standard for early identification today. First sign: persistent unilateral pain that doesn't improve with conventional ear infection treatments. If you have pain that affects only one side and persists for more than 6 weeks, even with adequate treatment, this deserves further investigation. Second sign: progressive and asymmetric hearing loss. If you notice you're hearing worse from one ear compared to the other, especially if this difference is gradually increasing, this may indicate auditory nerve compression by a tumor. Third sign: unilateral and constant ear ringing. The ringing caused by acoustic neuroma has specific characteristics. It's continuous, affects only one side, and is frequently described as a high-pitched, constant sound that doesn't vary with position or time of day. Fourth sign: episodes of dizziness or imbalance, especially when associated with other symptoms. Since the tumor affects not only the auditory nerve, but also the vestibular nerve responsible for balance, many patients report feelings of instability or dizziness, particularly when standing up or making sudden movements. Fifth sign: sensation of pressure or fullness in the affected ear. Many patients describe the sensation as if the ear were constantly plugged or under pressure, even when there's no evidence of infection or obstruction. If you've gotten this far and are recognizing some of these signs, pay close attention to what I'm going to say now. Dr. Carhart emphasized that early diagnosis is fundamental to treatment success. Small acoustic neuromas, detected when they still measure less than 2 centimeters, have much more conservative and effective treatment options. Modern diagnosis of acoustic neuroma has evolved significantly since Dr. Carhart's initial studies. Today, we use contrast-enhanced magnetic resonance imaging, which can detect tumors as small as 3 millimeters in diameter. We also have high-frequency audiometry, which can identify subtle hearing losses that aren't detected in conventional tests. But here's the crucial point. Even with all this available technology, many cases are still diagnosed late because initial symptoms are devalued or attributed to other causes. Dr. Raymond Carhart's pioneering work taught us that we should always consider the possibility of acoustic neuroma in anyone with persistent unilateral pain, especially if there's a history of acoustic trauma exposure. Let me share another case documented by Dr. Carhart that perfectly illustrates the importance of early diagnosis. Maria Santos, a 42-year-old nurse who had worked for 5 years in a munitions factory during World War II, began experiencing left ear pain in 1958. Initially, Maria ignored the pain, attributing it to work stress and age. For 2 years, she used over-the-counter painkillers and even some home remedies recommended by friends. It was only when the pain became so intense that it began affecting her sleep that she sought medical help. The first doctor she consulted diagnosed a chronic ear infection and prescribed a prolonged course of antibiotics. When there was no improvement after 6 weeks, she was referred to an otolaryngologist who, familiar with Dr. Carhart's work, immediately suspected acoustic neuroma due to Maria's occupational history. Tests confirmed the presence of a 1.8 centimeter tumor on the left auditory nerve. Because it was detected relatively early, Maria had the option of radiosurgery treatment, a less invasive technique than conventional surgery. 6 months after treatment, her pain had completely disappeared and her hearing remained stable. Maria's case shows us how knowledge of warning signs can make all the difference in treatment outcome. If she had sought specialized help at the first sign of persistent pain, the tumor could have been detected when even smaller, with even more conservative treatment options. Now, it's important to understand that not all unilateral ear pain is caused by acoustic neuroma. There are many other conditions that can cause similar symptoms, including chronic infections, temporomandibular joint problems, trigeminal neuralgia, and even cervical muscle tension. What Dr. Carhart taught us is that we should always consider all possibilities, especially when there are specific risk factors. What are the main risk factors identified by Dr. Carhart and confirmed by subsequent studies? First, previous exposure to intense acoustic trauma, whether through military service, industrial work, or recreational exposure to loud noises. Second, family history of acoustic neuromas or other conditions related to cranial nerves. Third, age between 40 and 60 years, which is when most cases manifest. Fourth, certain genetic conditions like neurofibromatosis type 2, although this is very rare. The investigation protocol developed by Dr. Carhart and perfected over the decades includes several steps. First, a detailed clinical history focusing on noise exposure, symptom progression, and presence of warning signs. Second, complete physical examination, including basic neurological assessment and hearing and balance tests. Third, complete audiometry with high-frequency tests and word discrimination assessment. Fourth, if there's clinical suspicion, contrast-enhanced magnetic resonance imaging for direct visualization of the auditory nerve. But here is something many people do and know. Not all acoustic neuromas need to be treated immediately. Dr. Carhart was one of the first to propose the concept of active observation for very small and asymptomatic tumors. This approach involves regular monitoring with imaging tests and hearing tests, intervening only if there's significant growth or symptom worsening. For small acoustic neuromas that cause symptoms, there are several treatment options. Radiosurgery, developed decades after Dr. Carhart's initial studies, uses high-precision focused radiation to stop or reduce tumor growth. This technique is particularly effective for tumors smaller than 3 centimeters and has a success rate above 90%. For larger tumors, or in cases where there's significant compression of adjacent structures, surgery may be necessary. Modern surgical techniques are much more refined than those available in Dr. Carhart's time, with lower risks of complications and better preservation of auditory and facial function. Can you imagine what it would be like to live without the constant pain that may have been affecting your quality of life for months or years? Imagine being able to sleep peacefully without being awakened by ear pain, being able to concentrate at work without the constant distraction of discomfort, being able to enjoy social activities without worrying about ringing or dizziness. Dr. Raymond Carhart's legacy goes beyond simply identifying a medical condition. He taught us the importance of listening carefully to our patients, considering historical and occupational context in symptom evaluation, and never underestimating apparently simple complaints when there are specific risk factors. It is important to mention that acoustic neuroma treatment should always be conducted by a multidisciplinary team, including otolaryngologists, neurosurgeons, radiation oncologists, and audiologists. Each case is unique and requires individualized assessment to determine the best therapeutic approach. It is also crucial to understand that many acoustic neuromas are discovered incidentally during imaging tests performed for other reasons. In these cases, when the tumor is small and asymptomatic, active observation may be the best strategy, avoiding unnecessary treatments and their possible side effects. However, when there are significant symptoms like persistent pain, progressive hearing loss, or balance problems, active treatment is usually recommended. The key is finding the ideal timing for intervention, balancing treatment risks with the benefits of symptom resolution. Dr. Carhart's work also taught us about the importance of primary prevention. Although not all acoustic neuromas can be prevented, adequate hearing protection in noisy work environments and during recreational activities can significantly reduce the risk of future development. For workers in high-risk industries, such as construction, mining, manufacturing, and military services, consistent use of hearing protection equipment not only prevents immediate hearing loss, but may also reduce the risk of developing acoustic neuromas decades later. Professional musicians and people who regularly attend concerts or events with loud music should also consider using specialized hearing protectors that reduce volume without significantly distorting sound quality. Awareness of the warning signs identified by Dr. Carhart can literally save lives and preserve quality of life. When healthcare professionals and patients are aware of these signs, early diagnosis becomes much more likely, leading to better treatment outcomes. It's also important to recognize that medicine has evolved significantly since Dr. Carhart's initial studies. Today, we have much more sensitive diagnostic technologies, less invasive treatment options, and better understanding of the natural history of acoustic neuromas. However, the fundamental principles he established remain valid. Attention to apparently simple symptoms, consideration of historical and occupational context, and the importance of early diagnosis to optimize treatment outcomes. The future of acoustic neuroma treatment is promising, with ongoing research on targeted molecular therapies, even more precise radiosurgery techniques, and non-invasive monitoring methods. But regardless of technological advances, the foundation established by Dr. Raymond Carhart will continue to be fundamental for adequate care of these patients. If you recognized some of the signs we discussed today, don't ignore them. Seek an experienced otolaryngologist and specifically mention your concerns about the possibility of acoustic neuroma, especially if you have a history of intense noise exposure. Remember, early diagnosis can make all the difference between simple treatment and complications that could have been avoided. Dr. Raymond Carhart left us an invaluable legacy by connecting the dots between acoustic trauma exposure and later acoustic neuroma development. His dedication to studying veterans and workers exposed to intense noise not only advanced our medical knowledge, but also saved countless lives through early diagnosis and treatment. Today, when we hear about veterans facing health problems decades after military service, or industrial workers developing complications related to occupational exposure, we should remember Dr. Carhart as pioneering work and the importance of never underestimating apparently simple symptoms when there is a specific risk context. Persistent unilateral ear pain may seem like a minor problem, but as we've seen, it can be the first sign of a condition that requires specialized attention. Knowledge saves lives, and sharing this information can help other people recognize important signs in their own lives or in the lives of people close to them. If this content was useful to you, share it with someone who might benefit from this information. Leave a comment telling us if you or someone you know has ever had a similar experience. And don't forget to subscribe to the channel for more health content based on solid scientific evidence. Your hearing health is too precious to be neglected, and the knowledge we shared today may be the key to preserving it for many years.